Thank you. Good afternoon. I trust everybody had a healthy lunch. I've never been asked to talk for less than 15 minutes, so I'm going to take David's time as well. But it's certainly a great pleasure for David and myself to talk to you this afternoon about some of the initiatives that have been going on within Southwest LHIN, there are basically three policies that we are currently working on. One is the Life for Limb, the extramural CCRT project, and David's going to be talking to us about long-term ventilation project. Critical care patients obviously are a very small group of patients that we, as a group, are caring for within our LHIN and across the province. But they certainly are our sickest patients, and we need to deal with them acutely and deal with them as a systematic approach to how to get the patient to the right place in the due time that they require to receive the appropriate care that they need so that we can reduce morbidity and mortality to the best of our ability. It's a challenge. Geographically, it's a challenge. Excuse me. Okay. There we go. With respect to the Life for Limb, No Refusal policy, this was an initiative that we thought about a great deal. One of the challenges that we have with critical care is that there are periods where we are very overwhelmed with the number of critical care patients that we have within our system. And so we discussed amongst ourselves, the Southwest LHIN, with our partners, the hospitals and alliances with the Southwest LHIN, trying to deal with how we're going to utilize the resources that we have currently so that we can distribute the load of these critical care patients and get them to the right hospitals in the right time. And I must admit, I have been overwhelmed and very pleased and impressed with the collaboration and the embracement of this policy by every one of our hospitals in our LHIN. And everybody has come to the table on this, and it's been reassuring, and I can assure you that the results that we're going to see from this are going to be very important in respect of improving patient care. And there's no doubt the Critical Care Secretariat is looking at this extremely closely because this is a project that I think, and we all feel, that should be taken across the province. This all started with Southwest LHIN, could not be happened without the support of the Southwest LHIN board for all three of these projects. So it's a very exciting time for us. And I must admit, we are also I'm very pleased with the collaboration that we are also receiving from the physicians who are involved in these projects. We essentially went to all our hospitals. We defined what a critical care patient, a Life for Limb patient is. These are the patients that are housed under the inventory of critical in terms of hospitals that can take care of these patients. Who's the closest referring hospital that can take care of these patients, and how are we going to get them in an expedient manner? It's a common language that everyone is becoming more and more familiar with. It's an understanding of a philosophy of patient care. It's not bed first, it's patient first. We deal about beds later. We have to take care of the acute process and utilizing the resources effectively and efficiently that we currently have. It's a platform for change. And the driving force of this, obviously, is improving quality of care for our ICU patients. We've started this implementation of this policy in February 1st. We now have 8 weeks of data that I'd like to share you with, just as a prime example of how well this is working. And I am somewhat surprised at the results that we currently have seen. Underlying all of this, of course, this whole project has been facilitated by the one number to call, which is a project initiated through London Health Sciences Centre. This has worked immensely and have facilitated the communication between a referring and receiving physician and with respect to critical care patients. We had a total of 75 cases, We've had a total of 75 cases and a weekly volume of 5 to 17 Life for Limb cases per week. The mean response time from a receiving physician is 8.8 minutes. So in other words, if a referring physician has a critically ill patient in a community whereby the resources of that community, expertise, has been outweighed by the patient's needs. They are now talking to an intensivist within 8.8 minutes. The mean accept times is 19, under 20 minutes. And again, a lot of this has been facilitated by the one number to call. So everyone is sort of getting on the line of one phone call, and we're expediting the assessment and the acceptance of these patients to where they need to go. It's really been reassuring. Now, what this policy is not, it is not punitive. As the policy states, it's a life or limb, no refusal policy. We also understand that under certain circumstances, certain times of day and night, that these patients may not be able to be taken care of at a particular hospital that we have contacted due to resource limitations. For example, if we require a general surgeon in a particular hospital, you may not have general surgery on call 24/7. If we happen to have it at night where the general surgeon is on call, that patient can be accepted. But if the general surgeon is not available, we need to go to the next hospital. Again, all of this is coordinated through the drop-down list and the inventory that we have housed currently in Critical. So they have been very important and a very important player with respect to making this work for us. It is not a LHIN-directed policy. It is a policy that has been embraced, a voluntary involvement by all the hospitals and alliances within our Southwest LHIN. It is not a LHIN-directed policy. It is a policy supported by our LHIN, but this is a systematic. These are the hospitals that are saying, we need to do this for the patients. It's the right thing to do. And lastly, it's obviously a living document. We've revised this since day one. We've implemented it, and it will continue to be revised. Continued changes of the definitions of life or limb, and how do we apply this most effectively within our limb. Now, I should be able to get this down pat by the time I'm done. It's not perfect. One of the difficulties with this situation is much improved, but the people that are receiving the calls are intensivists whose primary responsibility is on call in an intensive care unit. So if I'm on call today in the intensive care unit and I get a call from a community physician, I may not be able to take that call. Or I may not have the time to completely assess that patient over the phone, offer appropriate therapy, and worry about where are we going to take this patient and how this patient is going to get there. Because I'm busy. I'm responsible for an intensive care unit. And we realize that. So the next project, which we want to continue on, and we now have support from the Southwest LHIN, is to have an extramural CCRT team available to take these calls. Not unlike what's available now for pediatric critical care patients across the province. There's an ICU pediatric physician on call 24/7 to take referring calls 24/7, 7 days a week, okay? This is the project that we wish to implement for our Southwest LHIN. We're currently hiring a project manager and facilitating this new project. And essentially, for the pilot project within the Southwest LHIN, we have intensivists in London Health Sciences Centre who have volunteered to take these calls as a part of the critical care outreach teams that's currently funded by the Critical Care Secretariat. And once we facilitated this, we now will have physicians whose primary responsibility is not in the intensive care unit, but to take these referrals from referring physicians outside of tertiary care centers. So we will be able to assess the current needs of the patient. We will instruct early therapies for these patients, which we know will affect outcome, and we will be involved in terms of acting as a broker to determine where's the best place that's available for this patient to go. So the response times, the number of physician interactions should be reduced even further so that these patients are getting to the right place for the right therapy at the right time. So it's a very exciting time. I think I'm settled on that. So again, once this policy is implemented, we will have 24/7 availability of ICU intensivist referral. Again, the Critical Care Secretariat is again looking at very closely the results of this pilot project, which we hope will be up and running within the next few months. Now, I'm going to stop there and ask David to talk about the third project.
Thanks. What I'll talk about very briefly is a project that we've been involved with. It involves a number of people from both critical care and actually extending outside of ICU into the community and to other partners to look after patients that have chronic respiratory failure and require long-term mechanical ventilation. And this is defined as a need for technology to support breathing, either invasively or non-invasively for more than 21 days. And that really is our target group. And this target group has diverse diseases, which makes it a little bit more complex. Our current models of care for these types of patients are very complex. They're reactive to emergent problems. They're largely focused in acute care management and frequently managed in silos. Hence, it makes the care very inefficient. There's many barriers that exist at multiple transition points for these patients, and it results in unacceptable consequences for all individuals, their families, and it does create significant cost and burden to our healthcare system. So we truly do need new models of care that consider the system as a continuum for these patients and as a whole. And we need to redesign the delivery system to ensure that there's better patient flow and improved patient-centered care. Now, our objectives for this project are these 5 here, that we want to define and build a regional interprofessional system that optimizes the delivery of care to the long-term ventilation patients, including those at risk of ending up on mechanical ventilation. We want to try to be proactive with their care. And interprofessional, meaning that it involves many clinicians in terms of process. We've also tried to clarify the necessary resources, roles and responsibilities required to effectively and efficiently manage this type of interprofessional care system. We want to establish effective communication infrastructure and processes within and amongst the care providers and amongst various settings that they could end up in. Implement an interprofessional educational strategy that guides all, and also to create the tools that are necessary that encourage best practices. And these are various types of care maps, checklists, transition reports for these individuals. Now, this is my last slide, so I don't want to scare you away. It looks complex, but this is our model that we have been working with. And there's 3 entry sites for care of these individuals that we see, and we want to try to create an overlying system for them all. Patients may first of all present to us through our ICUs, and that's number 1. They are acutely in our ICU for medical problems on a breathing machine, and we want to try to identify those patients that we can move quickly through a process to say, yes, this patient is going to require long-term mechanical ventilation. Let's start focusing on that care now and on those transitions that are required. For every 1,000 patients that come through our ICU, probably around 100 patients end up in this definition of prolonged mechanical ventilation, requiring mechanical ventilation for more than 21 days. But then maybe 5 patients out of that 1,000 are identified that they're going to need this technology for many years or for the rest of their life. And so we want to try to move them forward to look at where their care would be best. Ideally, that would be at home if we could do so. And many of those patients may require invasive breathing through a tracheostomy tube and a machine. So you can imagine that there's significant processes that take place in the care of those individuals, particularly also to empower those individuals and their families to take care of these individuals in a home environment. We've also partnered with a number of other groups, particularly Parkwood Hospital in terms of complex care, where there are 5 beds for longer-term care of these patients. And so we obviously have to have very clear criteria for their care, for transfer of their care to Parkwood. And then we've also looked at other community sites and have made partnerships for other places of care for these individuals if it doesn't include home. You can imagine that if you're sending these types of patients to those community sites or home, that there has to be clear follow-up. So we've developed a chronic ventilatory care outpatient clinic to provide that follow-up care, because you need to have action plans for new problems or a new respiratory tract infection. And what happens? What do they do during that period of time? What's their next step? So we want to have clear guidelines in place for them. Under number 2 is another set of patients. These are the patients that are at risk for ending up on breathing machines. A lot of these patients have neuromuscular diseases. They come from the neuromuscular disease clinic at University Hospital, which provides a regional service and support. It also comes from regional ALS support, and these are patients that we want to identify early. Once they meet certain criteria, let's move them on to non-invasive ventilatory support. Let's put that equipment and that resource in place to manage them so they don't end up in our ICUs, for example. We want to be proactive. And we've been proactive to the point where we don't even want to have them admitted to hospital for this training and for the application of this equipment. We're now starting to work with an outpatient process in the application of non-invasive ventilation as well. Again, they need to be followed up in a long-term process, again, to take care of their needs. The third area where we're also having patients enter is from the pediatric side. There are kids being placed on mechanical support, ideally non-invasively if possible, with usually underlying neuromuscular diseases, that once they turn 18, the system changes, obviously, and a lot of the resource that's been in place for them falls apart, and they're expected to be cared for in an adult system. So we want to capture those. So we've looked at processes and working with our pediatric colleagues to capture that group of patients as well. So you can see that we're developing a complex system of care for our region, looking at all aspects of care for patients requiring long-term mechanical ventilation. So in summary, individuals requiring prolonged or long-term mechanical ventilation, either invasive or non-invasive, and those at risk of becoming so, can experience improved quality of life with efficient access to quality, safe, and appropriate care, which includes seamless and timely transitions across a continuum of care. Care coordination and collaboration is not only needed amongst multiple providers and sites, but also between providers, patients, and their families. This vision can only be achieved through an integrated service delivery model that is responsive to local health system needs and its strengths. Our purpose has been to identify the resources, both technological and human, that support the development of regional processes and skills that provide long-term ventilation of individuals access to the necessary respiratory and related care needs as close to home as possible, or ideally at home. In order to facilitate this, decision support technology will also be needed to ensure appropriate information is collected and communicated at the right time for the right patient. To this end, we've also been working with LHSC's clinical informatics personnel to enable a centralized environment of information that's accessible to all connected community hospitals and partners. Thank you.